This is All India Radio. Please stand by for our next program. This is Delhi. In our national program of talks tonight, the topic of discussion is battling Alzheimer. The panelists are Dr. Mathew Cherian, Chairperson, Care India, R. Narendhar, Executive Director, Alzheimer and Related Disorders Society of India, Dr. Jatin Tarwani, Psychiatrist, and Raji Nair, Media Personality, who moderates and initiates the discussion.
In today's stress-filled environment, what keeps us sane, rooted, and tackling each day as it comes with all its challenges is our mental health. This comprises of our emotional, psychological, and social well-being. It regulates how we think, feel, and act, and determines how we relate to others, deal with stress, and make choices. Today is World Alzheimer's Day, and the theme this year is No Dementia, No Alzheimer. No as in KNOW. To highlight the importance and the urgent need to disseminate knowledge and increase public awareness about this debilitating condition, we have an esteemed panel here to discuss the topic, battling Alzheimer. We have with us Dr. Mathew Cherian, Chairperson, Care India, Dr. Jatin Tarwani, a well-known psychiatrist, Mr. R. Narendhar, Executive Director of Alzheimer and Related Disorders Society of India, or ARDSI. A very warm welcome to the studios of All India Radio. Dr. Tarwani, I'd like to begin with you. If you can give us the difference between dementia and Alzheimer's.
First of all, dementia, it's an umbrella term. In this, many kinds of different typologies or different kinds of dementia comes. The most common among them is Alzheimer's disease. The common symptoms of dementia are loss of memory, which generally happens after a certain age of time, but to a certain degree that it starts causing dysfunction. Loss of language function, that person starts having difficulty in finding words and names, naming difficulty. Loss of motor skills, that he's unable to even use a comb or how to use shoes or how to use a mobile phone or how to use a remote. Then there can be sensory impairment, in which visual sensory impairment, for example, in which the patient has difficulty recognizing things, for example, difficulty recognizing the faces or certain objects, or auditory recognition, difficulty in recognizing these sounds. So these are the basic symptoms. Initially, the dysfunction is usually encountered in jobs, then certain social domains, then in the general life. The person is unable to shop for things, take care of the house, take care of the money, how to make food or travel. Subsequently, it goes further. Then in the last stage, the person is unable to dress himself, take care of his hygiene, take care of his toileting needs. So this way the person keeps on deteriorating. What matters is what kind of dementia it is. So for example, if it is Alzheimer's dementia, the deterioration happens over the period of 10 to 15 years. Alzheimer's is the most common, which is around 60% of all dementias. Secondly, if it is dementia with Lewy bodies, there are certain other symptoms. Besides these symptoms, there can be presence of visual hallucinations or Parkinsonian symptoms in which the person walks very slow from the very start. The third type can be vascular dementia. This happens after blood vessel in the brain gets blocked, which is generally called stroke. So a clot is there in certain part of the brain that will affect the personality or memory of a person. In this kind of dementia, the person usually have a stepwise deterioration. For example, he is at certain level of functioning. Then after 6 months, suddenly there will be a drop. After 3 months, there will be a second drop. After 2 months, there will be another drop. Unlike Alzheimer's, in which there is a gradual decline.
This is more faster.
It can be faster, it can be slower.
Oh.
Once it is diagnosed, a stroke is diagnosed, the person is usually started on treatment so that it does not recur again. So if he is taking treatment and taking care of other precautions, it will not happen. The fourth common type is frontotemporal dementia, which means that there is a frontal area of the brain, which is the forward area which controls the behavior, and there is a temporal area which controls the language. If the frontal area gets damaged, there can be two types of behavioral problems, either behavioral excesses or behavioral deficits. Behavioral excesses means the person will have very inappropriate behavior, he can become very sexual, he can spend lot amount of money, he can become very impulsive. Behavior deficits means he will become apathetic, not taking care of anything. Then the temporal variant, in which there is a language problem, there is sudden decline of language and eventually the person will become mute. So these frontotemporal dementias, which are not very common, these are associated with other kinds of problems of the body, in which, for example, there is muscular wasting. The person is unable to walk. Then there can be different dementias.
Let me interrupt you here. I also want to know if there's an alarming increase in the number of cases that you've been seeing in Alzheimer's, for instance. Or would you say it's been constant for the last few years?
It's largely constant, but what we read is just because the age, the life expectancy is increasing over the period of years, that specifically we see the effect over the period of decades, because the life expectancy is increasing, the usual age is increasing, so more people are getting affected by dementia. We don't usually see that in the practice.
Mr. Narendhar, what exactly does ARDSI do, and how is the organization going forward with this year's theme?
Well, this year's theme is No Dementia, No Alzheimer's. So ARDSI has 22 chapters across the country, and we have been organizing every day one or other event, especially to raise awareness. We also normally we run helplines. So once you raise awareness, the immediate after effect is that you get so much of calls.
Okay.
So once there are so many calls, then we need to equip that helpline to be effective. So we attend those calls, document them. Like of so many chapters, I would take the example of Delhi chapter. The moment we have some kind of awareness event, the next day or maybe the very day when the telecast or broadcast is happening, so we start getting so many calls. So our helpline is being properly equipped so that they receive the calls, document it, and then sometime we won't be able to reply them instantly. So then we record those things, their information, and then call them back. And then do a proper hand-holding, some of them may be requiring counseling, some of them may be requiring some kind of referral to a doctor. So we enable that kind of referral. And after that referral is happening, that gets into further kind of developments, like the doctors who identify and diagnose them with some kind of problem. So if they are poor, then they also send them back to us, and then we provide them some kind of free medicine.
And this is across all mental
across
diseases.
Most of my chapters do this. So that is how I would term ARDSI working in two major realms. One is in the primary mode and another one in the secondary mode. So primary mode would entail few things, like as I told you, helpline, counseling, and then referrals, and also providing some kind of free medicine. The secondary mode would essentially mean providing short-term care, long-term care, and training and other issues. And there is a third area which doesn't relate too much to services, but essentially that is also a very important area for us to work. So that includes creating advocacy, doing a lot of advocacy, because as an NGO, we can't just keep on taking care of people in perpetuity. We need some kind of support from government. So we do a lot of advocacy with government, and then see that some enabling schemes in which dementia can be included and taken care.
Dr. Cherian, as somebody who has worked with the aging population, what is your observation on the condition of Alzheimer patients in the different socioeconomic groups?
State of Alzheimer is such that there were about 3.7 million patients in 2010, according to the Dementia India report. And currently it is upwards of 5 million. The cases are increasing because all Indians have got a 20-year plus longevity. And as a result of it, all of us will live for 20 years more, which means that you will go beyond 80 and you will end up with diseases like the doctor said about neurological diseases, and one of them is Alzheimer. And the real issue in dementia across socioeconomic is the lack of care which is available, whether it is socioeconomic category which is poor, whether it is the middle class or whether it is the upper class. In the upper class, the issue is they can get paid formal care. But when it comes to middle class, usually the spouse or the relative is the caregiver. And in the poorer categories, there is absolute neglect. And in North India, there is a word which is used, unko satya aa gaya. Satya aa gaya means basically they have some form of dementia. And in many places, I have seen those people who are suffering from dementia and poor are left to die. They are not really cared for in many ways. And we also get some amount of dementia patients who have run away from their home and lost their way. So they end up in old age homes, and there they get some level of institutional care. But I would say the level of institutional care available in our country, including Delhi, is very, very low. There are few. In fact, if you look at the homes which cater to Alzheimer or to dementia, the number is very, very small. ARDSI used to run a home in Kerala. So having said this, the real problem is of the carer. The problem is not of the patient. The carer starts suffering from mental, psychological distresses because the pressure is so much. You have to be 24/7 with the patient, and the patient doesn't recognize you. They forget the name of the wife. They forget the name of their children. They forget so many things. And for the spouse and the children, it becomes a big form of distress because your father doesn't recognize you, or if it is a case of the mother doesn't recognize you. So neurological stress and psychological stress is something which psychiatrists need to deal with, and they suffer for a very, very long time.
After the patient
has died.
That is very
and
sad.
That is where ARDSI, of course, has a helpline. Helpline is for counseling and some support which can come on the telephone line. But I can say that is only marginal support, because actual support is to give hands-on support, which is not available across all socioeconomic categories. So that is the situation that we are facing through.
Today. Dr. Tarwani, is it genetic, and is it that women are more prone to it, to Alzheimer's?
Yes, ma'am. There are various risk factors, one of which is genetic. There is a person in the family who has had dementia or certain form of Alzheimer's or different things, then there is a chances increases that the son or daughter will also have dementia, though there are other risk factors also. And when all of these club together, the chances further increases. And secondly, regarding women, definitely women are more suffering from dementia. There are various theories given for the same, that post-menopausal, the estrogen, which is somehow involved in growth of the neurons, because the estrogen is not there after menopause, so there is no growth of the neurons, so there is degeneration. One reason is this. Second is women tend to live longer than men. So because they tend to live longer, so there are more chances of them developing dementia.
Mr. Narendhar, earlier in our conversation, you had mentioned how the attitudes have to change. That is very important. You stressed on that. The attitude of the patient and that of the caregiver. I mean, Dr. Cherian also mentioned the stress is so much.
Absolutely.
Can you elaborate?
So as of today, 2021, the number of people living with dementia in the country is 5.91 million. And this is going to be progressive, and in 2050 or 2030 it is going to be around 7.5 million, and by 2050 we are likely to touch 14.32 million. So that is the official figure. And for this, like Dr. Jatin was telling, like there is no constant increase in terms of number of people getting affected, but definitely age has been a determining factor. People tend to live long, so the chances of Alzheimer's is also getting much. And I would here stress upon the health-seeking behavior. When we talk about health-seeking behavior, in India, we have a very poor health-seeking behavior. Like Cherian was telling, he mentioned about a term called Satyagaya. So this is a very normal term which we attach. So this means that we consign a person who has memory problem as a natural outcome of aging. So that should not be seen like that. So aging doesn't mean that one should get Alzheimer's. So there has to be some kind of risk reduction which should happen right from the age of 30 plus. So one should have certain kind of lifestyle modification, which I think doctor would be much better speaking about that. But then Lancet report has already substantiated that 40% of reduction in case of dementia can be checked if we have a proper lifestyle right from the age of 35. Like check your vitals, check your diabetes, and avoid sedentary lifestyle. These things Ross University has very clearly stressed upon, that 40% prevention can happen from getting any form of dementia. And when I come back to the health-seeking behavior, especially in rural areas, are much poor because the diagnosis is not possible there, and people always, even the general practitioner available in the nearest health facility is not much aware about that. So awareness is the first point which ARDSI stress upon and work largely. And the second area is risk reduction, as I said. And the third area is dementia care management, which Mr. Cherian was telling. Like we do engage in long-term care as well as short-term care. When I mean short-term care, it essentially means running of daycare centers, or maybe having some short stay facilities where some family members has some important function and they have enough facility to take care of their dear ones at home, but then during those times they may not be in a position to take care, so they want some facility where their wards can be taken care. And similarly, there is the other one side is long-term care. So long-term care, normally, like, the disease has a progression phenomena. Once you move to severe condition, then this institutional care becomes mandatory. And the Indian custom is like that people don't prefer to send their parents to such kind of facility, thinking that there is a lot of stigma attached to this. So that is one issue that we need to address. And once again, for that, there has to be a lot of awareness. So awareness is, second thing is to enable right kind of diagnosis at the right time. So we want this diagnosis to happen early so that the quality of life to the patient can be ensured, because people come at a very late stage and that basically, like, they live with the condition for a while, they aggravate it and worsen it and then come for medical intervention. So that basically complicates the process of treatment for the doctor as well as for the caregiver.
Right. So Dr. Tarwani, would you say this is a lifestyle disease, and is it more so common among the urban population than in the rural, or is it seen across?
I will say that it's seen across.
Right.
This is number one thing.
Yeah.
So we have around 10 crore elderly in our country, around which 7 crore live in the rural area. Around 5% of the population among elderly, they suffer from dementia. As sir rightly said, it is 59 like 10,000 currently. It's a huge number. So it's present all along, but there are certain lifestyle issues which are definitely risk factors. You earlier mentioned regarding age, sex and genetics. So we definitely cannot change that. But we can work on other issues which can decrease the risk. For example, for Alzheimer's, if we have a proper diet. Proper diet means we are not taking too much of sugars, too much of salt, which are related with diabetes and hypertension. So we having proper diet, proper sleep, proper exercise. So that can reduce the vascular risk factors, which can cause stroke or heart attack, similar with the dementia. Other things are like engaging in social activities, engaging in other pleasurable activities, engaging in yoga, spiritual activities, taking care of all the medical problems when they occur at that particular time, not wait too long. For example, certain endocrine hormonal problems can cause dementia, certain infection can cause dementia, certain vitamin deficiencies can cause dementia. Then there are certain psychiatric problems. For example, depression in the old age and recurrent depression over the period of time. Depression is the most common psychiatric illness all over the world and in India, but sometimes they don't take treatment because of stigma or because of any other issue. So if we can take care of that, so the risk decreases significantly for Alzheimer's. Similarly, for vascular dementia, the risk may decrease if we can control our diabetes, our hypertension, obesity, if there are certain sleep problems. But overall, which can increase the risk of everything is alcohol and smoking. So we can definitely say that it's part of our lifestyle also, but it's present all across. Because this lifestyle is also seen in the rural area. The rural area is not free from alcohol, smoking, or taking improper diet.
Okay, Dr. Cherian, now would you like to add to that, the risk factors and how we can modify some of them which are within our control?
Yeah, one of the major risk factors is, of course, the social risk due to lack of social connectedness. One of the major problems of today's age is loneliness in the older population. And without children and without grandchildren around, many of them spend a lonely existence. Doctor said that they also then don't go for exercise, they don't go out to have a walk, etc., and they just sit watching the television, etc., and all their body parameters start showing higher blood pressure, higher sugar levels, etc. So this is one of the major. The other area is that we always say one of the preventive ways for old age, for getting any other disease, not only just Alzheimer, is actually eat your food in moderation, exercise in excess if possible, and be socially connected with your community, with your friends and with your things. So not just WhatsApp, but physical contact, so that you can have a better life.
What about reading and television and all? Does that constitute good things for older people?
No, reading and doing some activities to keep your brain, like Sudoku or puzzles or crosswords, etc., is worthwhile, because other parts of your brain get exercised. If you can start learning a new hobby like music or painting or something, or a language, then that will also help. But just reading more and more books is not going to help. And
what about television?
I don't advise too much of television because it becomes addictive. And mostly if you go and see older people at home, they're watching these serials throughout the day,
And
they're sitting, and so as a result of it, and these serials have some way of keeping them addicted. So it is not the best way. I would say get out, get some fresh air, go meet people, even if it is going to a temple, going to a church, Gurudwara, whatever it is, go do it, or go to a park, meet your friends or
Other
whoever
people
is
like
there,
you, yeah.
and stay connected. Of course, COVID has put a stop to many of it, but I am sure COVID will go away and people should
Resume
continue
their
to be
normal.
connected.
Yeah. And is it normal to expect all aging population to suffer some kind of dementia? Or is that too negative a picture?
No, I think aging, because of longevity, dementia is on the rise. Because I come from Kerala, and Kerala has the highest geriatric population in the country as a percentage, and longevity is also the highest because life expectancy is also highest. But the cases of dementia are also very high compared to the national average. So actually even the organization ARDSI started in Kerala and then spread to the other parts of India. So I would say aging has a direct correlation to dementia and Alzheimer's disease.
Okay, Mr. Narendhar, what kind of a national policy do we have in place to tackle the rising incidence of Alzheimer? And what are the key points, if you can tell us, if we have a policy?
Unfortunately, we don't have a national policy. But definitely there are so many complementing policies which partially address to the needs of Alzheimer's is definitely there. Like there is one program where Mr. Cherian and we were associated. That is National Program for Elderly, Older People. So that comes under the Ministry of Social Justice and Empowerment. And there we definitely have some kind of schemes for running care centers across the country, and even now there is a program for Dementia Care Center, and there is another program called National Program on Healthcare of Elderly, which exclusively looks at the geriatric population, and within that dementia is one component. And similarly, if you see, National Mental Health Act is there and program is also there, so even there is a lot of provision under National Health Mission. Every district has a provision of 83.20 lakhs available with them, but that money can always be put to use only when a small proposal kind of thing which comes from the district. So if you see dementia care, the first point, as I said, was to raise awareness. The second point is to ensure diagnosis. To make a diagnosis, there is a concept called setting up of memory clinic. So memory clinic setup hardly costs any cost. Like it doesn't involve much cost. But definitely the right kind of personnel has to be there. And the interpretation is once again done by medical professionals. And Kerala state has been a very big example in this. So they have an initiative called Kerala State Initiative on Dementia. And this initiative, if you see, there are two agencies which have joined hands. One is Kerala Social Welfare Board, another one is Kerala Social Security Mission. Both of them, they have joined hands and they have taken ARDSI as their knowledge partner. And all three of us, we are working on 4 areas. One is ARDSI provides them the SOP, that is Standard Operating Procedures, for how to set up a daycare center, how to set up a memory clinic, how to set up a old age full-time care center for dementia. So in that, we have also partnered with them and have started the first of its kind government facility in a village called Edavanakad in Cochin. So in this village Edavanakad, the local panchayat, social welfare ministry, social welfare board and Kerala Social Security Mission, all three of them have invested money, and existing old age home, first floor of it has been totally dedicated for full-time dementia care. Similarly, we also have one daycare center in a remote place in Guruvayur. So the village name is Chittanjur. In Chittanjur village, we have a dementia daycare center. This basically de-stress the patient as well as the caregiver. As he was telling, caregiver burden is a very big thing, and caregiver, once they are given some 8 hours of free time, so they can definitely concentrate much, and they are even gainful mode of like getting livelihood or other things, even that can be taken care when they are being allowed to leave their ward somewhere at a dependable place.
Right. Doctor, do you think a medical fraternity lacks the skill and knowledge required to diagnose and deal with Alzheimer's patients? And is there a lack of sensitivity?
Because the dementia, the diagnosis is usually made by psychiatrists and neurologists. These are the two main people. Of course, not everyone is diagnosed because majority of the patients, they present to primary care physicians, to the MBBS doctor, because they have other things to do, so they don't focus on this. So definitely sensitivity is lacking on that particular point. But once they come to a higher level, this is taken care very easily from the medical fraternity point of view. But the understanding of this diagnosis, the role of medical fraternity is very less in this. For example, they can make a diagnosis, they can start a treatment, but that pharmacological treatment or the psychiatric treatment or the psychotherapeutic treatment is very less. The role is very less. The majority of the role is of the social worker. For example, who will take care of the caregiver burden at home? If the patient is not taking bath, who will give them a bath? If the patient is not cooking, who will make food for them? So usually the social worker, for example, if there is a provision of such person, the person can come and give help to the family if the patient is staying with the family. In later stages, if the patient is staying in the old age home or a particular dementia care home, which we do not have, so the role majorly shifts to, we mainly need to put our money, our manpower, not towards the medical fraternity, because diagnosis can be made and intervention can be started. But eventually the last 8 to 10 years is majorly taken care of by the family, which can actually be taken care by a social worker.
What are the benefits of a timely diagnosis, and what is the protocol to follow once a patient shows signs of forgetfulness?
The benefits is basically like you ensure quality of life, definitely. The moment it is diagnosed at an early stage, the patient gets that right kind of care, and even the caregiver burden is a little less in that case. But if it is diagnosed at a later stage, then it is always on the reverse. Like people are more burdened and the condition is much aggravated. So in India, we only have 10% of cases rightly diagnosed. So we need to improve on that. And Maharashtra has now come up with a good example. NHM, they have a lot of projects to set up memory clinics in districts. So I think similar kind of initiative should be there so that diagnosis can happen at right time.
Okay, Dr. Cherian, if you were to give advice to the young and the slightly older generation on the kind of lifestyle to follow, what would be your advice?
My advice to young people is to always, after a certain age, start believing in eating less food. Moderate.
After about 35?
I think from 35 onwards you have to begin, and also have a rigorous exercise routine, even if it is 1 hour of exercise, and cultivate a whole lot of friends in society and in the community. And there is also a need for work in the community. And as you grow old and when you retire, many people then just start sitting at home. You can actually have a second career by serving your community, by doing some other social work, or do it with your own temple or your mosque or your church. Take up some activity or take up an alternate hobby. If you're focused on a single activity all your life, the chances of getting dementia are very high. So try to diversify your interests and develop other parts of your brain. And it is very scientific. If you develop other parts of your brain, your chances are much lower for contracting dementia.
I think I will conclude now with this quote: dementia care is not rocket science, it's heart science. So the big change needed today, even before a cure is found, is a change in our attitude. So thank you so much, gentlemen. It's been wonderful talking to you, and I think this was a much needed and a useful discussion, and hopefully many of our listeners would think so too. Thank you again.
Thank you.
Thank you.
In our national program of talks tonight, you were listening to a panel discussion entitled Battling Alzheimer. Panelists were Dr. Mathew Cherian, Chairperson, Care India, R. Narendhar, Executive Director, Alzheimer and Related Disorders Society of India, Dr. Jatin Tarwani, Psychiatrist, and Raji Nair, who moderated and initiated the discussion. Produced and presented by Naveen K. Gupta, this was a presentation of Delhi Station and came to you on AIR Live News Channel 24/7.